Welcome to the Cognitive Impairment Research Group workshop on delirium diagnosis and management. I, Mas Mohammed, will present part 1 of 4, where we consider what is so important about delirium and why it is relevant to psychiatrists. One helpful way to get an overview of the issue of delirium is to ask ourselves, if we had to make a case for increased resourcing to address the problem of delirium to, for example, our Minister for Health, what is it that we would tell him? First of all, a wealth of studies over the past 2 decades have highlighted just how common delirium is in different settings. Conventional wisdom therefore suggests that perhaps 1 in 5 people in our general hospitals experience delirium at some point. Traditionally, this figure is extrapolated from these studies by creating a virtual hospital by combining data from different settings. With that in mind, a particularly compelling study is that by Ryan and co-workers, who perform a point prevalence study of all medical and surgical patients in a university teaching hospital in Cork, in the south of Ireland. Over a 36-hour period, they assess almost 90% of inpatients for cognitive impairment, and then specifically with detailed assessments for delirium and dementia. Their findings highlight how discernible cognitive difficulties are common in hospitalized patients, occurring in around 40% of inpatients, but importantly, demonstrated that 18% have syndromal delirium when assessed cross-sectionally. Also, of these, over half have comorbid dementia. This study therefore supports the 1 in 5 rule. We will return to this study and its methods later, as they illustrate something useful about delirium assessment and diagnosis. Delirium is important not only because it is common, but also because it has such a major deleterious impact upon outcomes. Patients with delirium experience poorer outcomes in terms of just about every significant healthcare parameter, with longer hospital stays and costs of care that are typically twice that of equivalent non-delirious patients. Additionally, they are much less likely to return to independent living. And after the acute episode of delirium, they frequently do not recover to previous cognitive functioning due to persistent cognitive impairments and are 3 times more likely to receive a new diagnosis of dementia in the following year. Finally, and perhaps most significantly, they experience substantially elevated mortality rates. Importantly, these outcomes are relatively independent of other potentially confounding factors. In other words, although patients who are older, have pre-existing cognitive problems, and who are very sick are all more likely to experience delirium, those who do have even worse outcomes that are at least in part accounted for by delirium. This meta-analysis by Witloxet et al. Is particularly revealing in this regard, as it includes findings from over 50 outcome studies and shows an increased risk of subsequent institutionalization and mortality in delirious patients, even when the analyses are adjusted to account for age, comorbid illness severity, and baseline cognition. In short, experiencing delirium is bad, both in the short and long term. To labor on this point for a moment, in respect of mortality as an outcome, this interesting study by Gonzalez et al. Puts a temporal magnitude on the relationship between delirium and death, concluding that in elderly medical patients, mortality is increased by 11% for each additional 48 hours of unchecked delirium. This study is particularly useful as it highlights the importance of timely recognition and treatment. But apart from all the impersonal macro healthcare outcome statistics, at a very human level, delirium can frequently be devastating for sufferers and their families. Sometimes, qualitative research can capture things in a particularly powerful way. And so, this study from Japan on delirium in palliative care where the testimonies of families demonstrate why we need to manage this condition so much better. You can see how it highlights the sense of embarrassment, confusion about what it represents, and a sense of shame, with a sense of desperation so great that for some it provokes an extreme level of distress and thoughts of extreme behavior. For a good example of the delirium experience, you should check out this short video link on YouTube. Unfortunately, the delirium story gets even worse. Although delirium is both common and has major deleterious impact upon outcomes, it is often missed. In fact, studies indicate that more than 50% of cases are misdiagnosed, detected late, or missed completely across healthcare settings. And as this slide of recent studies exploring delirium detection shows, this is by a full range of healthcare professionals who have contact with delirium in their everyday practice. Check out the example of an assessment of a delirious patient on the video link. As this short clip demonstrates, unfortunately, modern time pressurized healthcare environments are often poorly designed to pick up on even florid delirium. So, in an effort to try and raise awareness of delirium, maybe we need to liken it to MRSA, perhaps by calling it the cognitive superbug. It is omnipresent in healthcare settings and both preventable and treatable. One can only speculate as to the potential healthcare gains if we could direct as much attention to delirium as we have done for MRSA. To our Minister of Health or other significant decision makers, we might say, 1 in 5 hospitalized patients have a condition that is independently linked to poor outcomes, more than half of which is missed or misdiagnosed despite being treatable. The argument for better delirium care, therefore, seems compelling. Having stated the case for delirium in general, we now turn to psychiatry. Psychiatrists undoubtedly have special skills to bring to our efforts to achieve better care of delirious patients. In particular, their knowledge of neuropsychiatric symptoms, coupled with their familiarity with commonly used psychotropic medications for delirium, bring important skills to the assessment and management of delirious patients. This image of delirium, collected by the Danish doctor Einar Brunik, was published in the British Journal of Psychiatry in 2007, but dates back to 1919. And I think it beautifully captures the complex array of symptoms that can occur in a delirious patient. Capturing this complexity in a more scientific perspective, this study shown in this slide was conducted by our team in Limerick, and it is a strong study because it involves detailed assessment of a broad range of features and also gives a sense of the severity of disturbances. The study highlights the breadth of symptoms that occur in delirium, and although these disturbances lack specificity, with no single pathognomic feature, the character of some disturbances, for example, sleep-wake disturbance intensity, and their breadth and pattern, typically fluctuating, as well as their acute presentation in the context of serious medical morbidity, are all highly indicative of delirium. In fact, one might usefully ask, what else can cause this range of symptoms in hospitalized patients? The skills of psychiatrists in accessing these neuropsychiatric symptoms make their input particularly valuable in terms of understanding delirium and also in assessment of complex cases. It is thus reassuring that psychiatry is well represented in the membership of leading international delirium-focused organizations such as the American Delirium Society, and as shown here in this recent survey of European Delirium Association membership. So, in summary, delirium is an extremely common and serious problem in hospitalized patients, and it is poorly detected. In part 2 of our workshop, We will consider how delirium is defined and how we can approach diagnosis in everyday clinical practice.